We always begin a 10-step protocol with a still point induction. And the still point can be induced from the feet, from the legs, from the sacrum, from the head, from essentially anywhere in the body. The point in inducing a still point, the objective is to enhance extension or external rotation is inhibited. So what we do is we take a hold of the feet if we're going to begin here, and we follow the craniosacral rhythm into internal rotation. And we don't push at it, we just follow it. And then when she attempts to externally rotate, we resist. What happens is the system itself seems to begin to work against your resistance, and ultimately it becomes disorganized, stops, and it almost feels as though it is indeed reorganizing itself for further work. And essentially that's what happens. You get this still point when the craniosacral system completely shuts down. That could last for anywhere from 30 seconds up to several minutes. When the rhythm begins again, it usually begins with a higher amplitude, and it begins with a better rhythm, perhaps slower, perhaps more even, but you will notice improvements. And in this case, what's happening is she's going into internal rotation, and she's almost immediately stopped trying to externally rotate. As you recall, external rotation is equivalent to flexion in the system. So she's into a still point right now. If you watch closely, you can see that her breathing has changed a little. She's taking slower, deeper breaths. And I'll just hold on until the still point is over. Now, when I do this through the sacrum, I could do it by following into extension, and as you recall, the sacral base goes anteriorly during extension. There, her rhythm's coming back now, so I'll follow it. We reevaluate and decide whether we've achieved what we want to achieve by having that still point. If I were going to do it through the sacrum, I put my hand right through here, and you can see I apply it. I hold the sacrum in the palm of my hand. I lay her back on the table, and now when she goes into extension, I will follow the cranial base anteriorly, and when she tries to go into flexion, I will resist it, and that would be the movement of the cranial base attempting to, or the sacral base attempting to go posteriorly. She's very easy. She's going into a still point immediately, almost upon touch. That means our model is either scared or the patient is really willing to feel better. The release feels like a softening and a lateral spread. Feels like her whole pelvis is beginning to spread laterally. The ilia are moving laterally. The sacrum is flattening and becoming softer. The pubes themselves feel like they're opening. And I will just stay with this for a minute until it feels to me like it's totally complete. And there it is, complete. Now, at the same time I'm here, I'm going to go back to that center hold, Vincent, and I'm going to take the sacrum, and I want to just stabilize the lumbars with my other hand, and I'm going to move the sacrum inferiorly and make sure that it's free to move. After all, the sacrum is the inferior handle of the dural tube, and if that handle is stuck, then the dural tube can't move. Now, what's happening here is her right sacroiliac is fine, but her left one is sticking. So I can take the anterior superior spine on this side, the anterior superior spine on this side, compress the two, and that gaps the ilia posteriorly and allows me to get some freedom in that left sacroiliac that's giving us a problem. If you don't find it easy for you to do it this way, you can have the patient use her hand on both superior spines, and please push right toward the center here. Push the bone itself. There, now as she does that, she's gapping in the back and I'm getting freedom. That gives this hand the ability to do something else if it wants to. And remember, your hands are the boss. There, now her left sacroiliac is freeing up very nicely. And now I want to go under and check these lumbars and be sure she's not got a lumbosacral compression. That's free. Very nice. Thank you, Gail. If you run into a lumbosacral compression that is really difficult, there's another way to do it, which uses the legs as long levers, and you put your hand just above the pubes as a fulcrum, and you come up this way. But remember, go easy. When you feel the resistance beginning to build up against you, that's where you wait, and you begin to push inferiorly on the pubes, very gently with your hand on the anterior abdomen, and there goes. I can feel the compression or the separation of the sacrum from the lumbars very clearly now. If there was compression, it's gone. She's separating beautifully. Excellent. Okay, now we move on to the respiratory diaphragm. And in order to do this diaphragm, we want one hand in the back over the thoracolumbar junction. I like to have the spinous processes of T11 and 12 in my hand, and I like to have it spread out all the way down to L2. In the front, I'm going to just have the tip of the xiphoid process in my hand, the anterior rib cage as it comes down, and now that I've located my anatomical landmarks, I lighten up my pressure. The third step in the 10-step protocol is the frontal lift, and it's with the frontal lift that we begin to alleviate any abnormal tension in the vertical membrane system, and it's the anterior-posterior aspect, which means it is the falx cerebri. Now, Mother Nature's been very nice to us. She's provided two nice ridges, and if you feel them in your head right along the corner of the eye, I usually put a fourth finger there, let the rest of my hand cover the frontal bone, and then just very gently begin lifting the frontal bone directly toward the ceiling. And it won't take very long until you feel the frontal bone begin to move. Remember, there is a bony or sutural restriction that can occur. That's rigid, and after you get through that, then you have the elastic aspect of it. And this is the sensation that if you let go of the bone, even though it's moving, it would spring back to where it was. As long as you have that going on, you're going to get temporary relief but not permanent change. So you want to continue your frontal lift, or all of the techniques that involve sutures and membranes. You want to continue the technique until that elastic quality has disappeared. And in this case, the frontal is coming off very nicely. Remember, the frontal has suture that connects it to the parietals, to the sphenoid, and it contributes to the roof of the orbit of the eye. And so it has a lot of activity going on in both the cranial base, where it forms the orbits, and it connects with the ethmoid. If the frontal is jammed, the ethmoid bone will not function well either. Her frontal is lifting extremely well. I am now into the membrane system. I can feel the falx cerebri beginning to stretch, and now it feels as though the frontal bone is coming right up and beginning to float toward the ceiling. I'll hold it there until I feel it sort of soften, release, and stabilize. And that is the frontal lift. The fourth step in the 10-step protocol takes further consideration of the anterior-posterior membrane, but this time we're going to move the membrane cephalad. And we do this using the parietal lift with traction. This is a two-step technique. The first part of the parietal lift, we use just medial compression, and we allow the parietals to come out from between the temporal squami spontaneously due to fluid pressure changes inside. The next, then we allow it to relax, and this seems to allow a good fluid exchange in the head. Then the next piece is we're going to use traction on the membranes themselves, and this is a good time for you to begin learning what it's like to project down the dural tube and sense where it goes. I will describe that to you as it occurs for me, and I think you'll begin to understand more what I mean. Now, one mistake I see quite often with parietal lift is the thumbs are on top of the head. The thumbs should not be touching the top of the head, because if you want the parietal bones to come toward you, why in the world would you prevent that from happening by putting your thumbs on top of their head? So let's be sure that we get our fingers above the temporoparietal suture and posterior to the coronal suture, which is in the anterior part right about here. So we'll go above the temporoparietal suture, posterior to the coronal. I cross my thumbs on the top, and I begin to put a little medial compression on both parietal bones and wait for the parietal bones to come toward me. They respond beautifully. She's moving medially with her parietals. She hasn't started the cephalad release yet. Here it comes. The left parietal is coming towards me. The right one is maintaining. There's a little sutural restriction on the right. I'll follow this, and the whole parietal complex is shifting over towards her right. You follow it. The only force you're putting in is the medial compression on the lateral aspects of the parietals. Now it's swinging back over to the left. This is her way of self-correcting. She knows a lot more about how to fix herself than I do, so I'm here to help her, not to decide what needs to be done. Now, both parietals are beginning to come toward me, and they're doing a little. I can still feel a restriction in the right temporoparietal suture, so I'll maintain my medial compression. I would like that to come apart by itself. If indeed it gets too resistant, I can use a V-spread across here. And I think I'll do that just for demonstration purposes. To do a V-spread on this suture, I'm going to put one finger on the temporal, one finger on the parietal. I'm going to use my other fingers from across, and I'm going to direct energy directly between my two fingers into the suture and get the suture to release. In doing a V-spread, the first thing you notice is you get the pulsation, and then the suture releases, and here it comes. I can feel it because the parietal is now coming toward me very well. All is the sphenobasilar compression-decompression technique. We have completed the treatment of the vertical intracranial membrane system, and now we're going to get into the horizontal membrane system, which is the tentorium cerebelli. The tentorium attaches posteriorly to the occiput, and its anterior-most attachments are to the sphenoid. So we're going to use the occiput and the sphenoid in order to accomplish this technique. I will first just support the occiput on my fingers in the back because I want to have a sensation of what it's doing. I could do this just directly on a table, but then I wouldn't have the knowledge of what the occiput's doing. My thumbs I will place over the great wings of the sphenoid, and I very gently begin to compress the sphenoid posteriorly into the table with my thumbs while supporting the occiput in the back with my fingers. And as the sphenoid and the occiput begin to approximate each other, we will be doing that latching-unlatching principle. For example, if you have a stuck drawer, sometimes it helps to push it in before you pull it out, or a jammed door. You shove it shut first real hard, and then it'll open easier. Well, we're not going to shove this, but we're going to compress it gently. And as it does, any malalignments that may be present between the occiput and the sphenoid will begin to show up, as this is now. The right great wing of the sphenoid is coming towards me in the cephalad direction. The left one is going inferiorly, which means that there's a torsioned relationship between the sphenoid and an occiput, and I'm exaggerating that malposition, and it will correct as we go. Now, I'll keep going in this compression technique until I feel the head begin to soften and widen laterally. And I'm just beginning to get that sense now. So I'll keep on with the compression until it feels like it's released. She's going into a very large flexion movement now. And if you think about it, when you compress the two bones, you are enhancing flexion. There, she's gone into big flexion, and it's very nice. So now we just take a second or two, relax, and come on. Now we're going to decompress, and in order to do this, I use my thumbs to suspend the sphenoid toward the ceiling. I suspend it from my thumbs, and I lift it until I feel a lightening of the weight of the occiput on my fingers posteriorly. Once that lightening occurs, I maintain that position until the occiput begins to settle into my fingers. Then I lift some more. And I'm lifting toward the ceiling. This is a very nice compliance here. She's going up. It feels like 1/4 of an inch. Obviously not the case literally, but it feels that way. And the occiput is remaining in my fingers. So I'll keep going until the occiput lifts Just a little bit. Still not lifting, and the sphenoid is going. We're going into tremendous extension maneuver here. I repositioned my thumbs because they began to slip, and if you do that quickly, you won't lose the technique at all. Now we keep on going, and look at the breathing change. Is one that is aimed at mobilizing the temporal bones. Now the temporal bones have a tremendous amount of ability to be restricted. We will use them in step number 7 to mobilize or to treat the horizontal membrane system laterally, but first we want to be sure that the sutures of the temporal bones are alleviated before we try to move the temporal bones in their lateral direction. First I'm going to do a technique called the temporal wobble. In this technique, I support the head, as you see, with my hands, and I take my thumbs and I apply them to the mastoid processes of the temporal bones. And first, what I want to do is take one thumb and move a temporal bone medially at its mastoid tip. Let it go in, let it come out, and then do the opposite. Now I'm going to start with the right thumb, and I'm moving the mastoid tip of the right temporal bone in a medial direction. And it goes in very slowly, and I allow the one on the left side to come out at the same time. Now that seems to be the range, and so now we will apply pressure on the left side and relax on the right side and let the right temporal mastoid tip come out. And we just wobble this back and forth a few times until it begins to be free to move. What we're doing here is we're beginning to mobilize a lot of the sutures that go all the way around the temporal bone and the petrous ridges. The temporal bone, as I say, is very frequently stuck, and it is the key problem in a lot of cases of dizziness, also in cases of strabismus, because it has such a big role to play in the tension that's in the tentorium. And recall that the oculomotor nerves do indeed run between the two layers of the tentorium. The inner ear, the balance mechanisms are all located inside the petrous parts of the temporal bone. And so when the temporal bones get jammed, either in internal rotation or external rotation or any other way, you get a lot of problems that have to do with balance, equilibrium, hearing, buzzing in the ears, all of those kinds of things. Temporal bones, when they're severely restricted. Okay, the 7th step in the 10-step protocol is the temporal decompression, which in parenthesis we call the ear pull. And we use that to release in a lateral direction the horizontal membrane system. The temporal ear pull came from my experience at the Center for Autism. We're figuring out how to release the temporal bones laterally, and finally, in a stroke of genius, it became very clear. The ear is attached to the temporal bone, and so if we pull on the ear, it'll pull the temporal bone laterally. You just put your thumb in almost into the ear canal as much as you can, grasp the ear, and then very gently pull laterally, equally on both sides. Follow any kind of rotation that occurs, follow any kind of anterior, posterior, superior, inferior movement. Your force is in one direction, it's lateral and slightly posterior. You're just inducing one force and you're following all the rest, remember that. What happens is now we begin to come laterally. She was rotating, imitating that finger in the ear technique for a while, and now she's beginning to come laterally, and we have a lot of elastic resistance. No rigid bony resistance, but a lot of elastic resistance, especially on the right, and that kind of fits in with the other problems we were having on the right side of the temporoparietal suture on the inside. Step 8 is the temporomandibular joint compression decompression. And this is a very popular technique because temporomandibular joint problems are so popular these days. First, we want to compress because we want to compress the joints, and we will use the compression phase to raise the parietals, to rotate the temporals, and actually the traction into the internal membrane system. Then when we decompress, we'll decompress the temporomandibular joints and balance the mandible. Mother Nature's been very kind. She's provided a little notch right here in the mandible, and we hook our fingers around that. Then we lay the hand very gently up the side of the head and very gently begin to traction the mandible towards the head or towards yourself. As you do, you will notice an imbalance. In this case, the right side of the mandible is high and the left side is low. That indicates to me that the right temporomandibular joint is already compressed and the left temporomandibular joint is not. So we're going to continue the compression and get a balance between the two. As we do, since the joint of the temporomandibular joint, or the fossa in the temporal bone, is located anterior to the axis of rotation, it puts us into an internal rotation phase of the temporal bones. When that's carried to its extreme, it begins to lift the temporal bones, which in turn begins to stress the temporoparietal suture. That in turn begins to lift the parietals in their lateral aspect, and we'll take that as far as it goes until we begin to traction the falx cerebri on the inside. And as you practice this technique, it's a wonderful way of getting acquainted with all of this anatomy and the way it interplays with each other. We're going to move down to the dural tube evaluation. We've completed the work with the intracranial membrane system, and we've completed the mobilization. We've also mobilized the occiput and the sacrum. So what we want to do now is pay a little special attention to the dural tube. And in order to do that, I'm going to put one hand under the sacrum, and you can just roll up here. You can see my hand is just holding the sacrum very nicely, and the other hand under the occiput. And what I want to do is I want to move the dural tube up and down. Remember, it has a centimeter or two of movement that it's able to accomplish inside the spinal canal. So I'm going to traction toward the head on the dural tube using the occiput as the handle on the cephalad end. And when I get all the slack taken up there, which is now I'm beginning to feel a sacrum pull toward the head, I'm going to reverse and I'm going to take the sacrum inferiorly and get the dural tube to express its traction upon the occiput. And I want to see how much space I have between there. She has a nice mobile dural tube in there. Some people who've had injuries, they may have had back surgeries, they may have had cord tumors or things like that, you will spend a lot of time mobilizing the dural tube. People with arachnoiditis, this is, from my point of view, the treatment of choice, although it exacerbates the pain at first. Because what you're doing is you're mobilizing the whole membrane system within the spinal canal. If there's inflammation in there, it's the way to get the inflammation taken care of, but it's also painful in the process. And her dural tube feels just fine. If you have questions about it, you can go back to that sacral hold down below and just do the sacrum and bring the dural tube to you, and you can use the occiput and bring the dural tube up towards you. But to exercise the dural tube, it's just a question of taking your two hands, occiput, sacrum, doing this until you get the response here, then going inferiorly till you get the response here and get a follow. And keep doing that. In order to do that, I lay one hand on the other. I touch my two thumbs like that. And what I want to do is have the posterior occipital protuberance placed between the thenar eminences of my thumbs. I put this underneath and allow the patient to rest their head completely on my thumbs. The points of my thumbs, or the point of the V that they form, will meet just at the inferior end of the occiput, or perhaps at the spinous process of the first cervical vertebra. The reason we do this last and we do it this way is, since you're beginners, or since you're, let me be more gentle and say you're lacking a certain level of experience, you may have induced some stresses or patterns within the craniosacral system that you're not aware of and that would not be beneficial to the patient. If you finish your 10-step protocol with this technique, it will repair any inadvertent dysfunctions that you may have induced in the system. Not only that, it's good for the patient's health, and we do it in the same way as we did the other ones. We just follow the narrowing of the occiput during the extension phase and then refuse to follow when it tries to expand in flexion. This technique can be used effectively to reduce fevers. I have used it on fevers as high as 104 and gotten a 2 or 3 degree Fahrenheit drop. The interesting part of that is if you do it 2 or 3 times in a row, the fever does not recur. It seems to take the patient through the crisis of the problem and gets them into the healing phase wherein the fever is not so high. We also use it to enhance vitality. When I was still teaching at Michigan State University, I used to teach students to do this to themselves using tennis balls, and I think you've all become acquainted with our tennis balls. And they would do this during exam times and so on, and it seemed to, in their opinion, give them a better response on their exams and so on. They could think more clearly. It's a technique that you also use anytime that fluid exchange would be helpful. And I use it in all the arthritic problems because fluid exchange is so important in inflammatory processes. And so it's an excellent technique to teach to a family member for someone who's suffering from rheumatoid arthritis or some such debilitating disease. We also use it a lot with transient problems.